Hey everyone, welcome back to another exciting episode of Ascom's Ask the Experts. I'm Dave Gutillo, Director of Healthcare Market Innovation for Ascom in North America, and today I'm joined by Angus Douglas, who's a technology strategist and chief solutions architect with GE Healthcare. Angus, before we get into things, let's have you chat with us a little bit about yourself.
Well, how much time do we have?
As much time as you need.
So I started my career with Motorola when cell phones first came out. So I spent a lot of time in the wireless segment. About 36 years ago, I got into healthcare, developing software. I eventually sold my company and moved into the patient monitoring world. And that's where I really first encountered the need for mobile technology to support clinicians in the areas of alarms and access to information and real-time visibility of their patient. And for the past close to 20 years now, I've been focused on a lot of these technologies of alarm management, of clinical communication, real-time location systems, virtual care, and all the ways that we're aggregating information and mobilizing information for caregivers to be able to respond more quickly to their patients and end up with better outcomes.
So you've definitely seen an evolution in technology as well as process, and that's really enlightening for us. When you think about unified communication, secure messaging, clinical collaboration and communication, there's a lot of buzzwords that are out there, but essentially what we're seeing is healthcare evolve more towards this idea of a broader, more systemic system, a platform approach. When you think about end-to-end connected care as a platform, could you describe for our audience what that means?
Well, starting with clinical communication, the very first forms of clinical communication was voice calling, paging, and alarms. Those were the first ways that we kind of mobilized communication. And when I think about alarms, I really see us as, in my mind, as at about the fifth generation of alarm management and notification. Generation one, we had one-way pagers in the late 1990s, and we sent an alarm and prayed it got there. Generation two, we had two-way pagers. Now we knew if somebody got it, if they were on it, or we could escalate it, and that added an additional safety net. Generation three, we started adding clinical context, and that was pioneered by Data Critical Corporation that GE bought in 2001. And there we had a snapshot of a waveform or additional clinical information to add context. And that's really where a lot of people still are. However, we took it to Generation 4 in partnership with Ascom and Airstrip, where in Generation 4, we were able to bring in live data, because what's happening with my patient in the moment now? Was it a sustained event, or was it a transient event? Do I need to drop everything and run to the bedside, or can I back out gracefully? So we've been doing that since about 2014. And then Generation 5 is where we integrated clinical communication. So just looking at that trajectory, each step of the way adds dependencies of systems. And just look at the pathway of a single alarm, starting with the source, and then going to the rules engine that manages it, then going to some form of dispatch or visualization for the caregiver, and then their response back. There's a lot of steps, and we need to kind of look at the overall pathway and experience end-to-end in order to have dependable systems. And in the post-COVID world with virtual care, we now have even more integrated and broader systems that require a truly unified ecosystem, as well as broad team-based collaboration. And so to really deploy end-to-end effectively, you've got to not only design it in a different manner, you've got to integrate it, you've got to add system monitoring between all these steps, and to truly have end-to-end testing. And that requires a lot more than just deploying a technology.
That's fantastic. You mentioned a couple of things that I want to maybe take us a little deeper on. One of the areas that you mentioned was this idea of system dependency. And you also mentioned this idea of an ecosystem. And we know that this connected care, I think you said most customers may still be at step 3 or step 4. And we recognize it's a journey, right? There's a lot of health systems and hospitals that are probably at various places within that journey. What would you suggest to our audience in terms of, some of the common challenges that they're facing, maybe some of the things that are pitfalls that, you've seen in your experience for them to overcome, as well as maybe some of the best practices?
Sure. Well, I think the best practice is, first of all, to recognize that these are not technology projects. These are clinical transformation projects. And so we really need to go back to the bedside, and you can't just append one system on top of another. So I've got communication, now I'm going to add alarms or visualization or EMR integration. You really have to reimagine the workflow, because otherwise you get either you layer old patterns on top of new technology, or you get unanticipated results. And one example that just came to my mind the other day was I was working with a healthcare system deploying smartphones, and they're still having their on-call doctors take a smartphone and hand it off to the next doctor who's on call. Well, we did that with pagers and feature phones, but now we have software that I can have your schedule automatically update you, and you become the on-call person without ever having to connect physically and hand something off. I mean, just really reimagining, and that's a simple example, but really reimagining the way workflows work. And the other part of it is also to work backwards from the clinician at the bedside and backwards from the patient to kind of reimagine. How do we eliminate manual steps and reduce the cognitive load that is so high today in today's overworked clinical teams? And then as far as some of the challenges, I mean, number one is not focusing on adoption. So we often try to look at the workflow, and we're looking at the outcomes first. Get people using the system. Get their both feet in the water and using the technology, and then you can layer on workflows rather than boiling the ocean. And the other kind of challenge we see and that people do is in the desire to have simpler systems, fewer vendors. We see a lot of health systems over-relying on their electronic health record provider. And those companies are great companies, and they make great technologies, but no company can be all things to all users and all applications. And so the challenge is people are trying to often do too much with their EHR because they say, oh, sure, we can add that function. But it's kind of like, and we're going to borrow this and give credit for this analogy to Anna Baker Garber, who was previously the Chief Nursing Informatics or Chief Informatics Officer for HCA Healthcare nationally. And she likened it to using a Leatherman tool. So it's got a lot of tools and a lot of cool little uses, but sometimes you need a real screwdriver or a real set of pliers to get the job done. And the more complex these systems become, and as we move into virtual care and some of these other surveillance applications, really you need to look at what's the best tool and not necessarily totally trying to rely on one vendor for everything. So those are just some of the areas that I think that we see in common and across the industry.
Wow. There's a lot to unpack with that. I'm really glad that you mentioned the idea of incremental adoption, right? You know, taking it one step at a time, not trying to boil the ocean. And the other thing too is this idea of, start where you are and then look at pulling in the experts to really be able to optimize what you're doing over time, right? Because
yes,
and I think that's probably a nice segue. When you start to think about adoption in healthcare, what are some things that you've seen in terms of impact? I know a lot of these projects, you said, again, you can't boil the ocean. They try to take on too much and it ends up being ineffective. So are you able to kind of point to some things relative to adoption? Maybe it's in care areas or specific types of areas where they're going to get the most impact. What kind of things are you seeing where either it's an in parallel or a sequential or some combination thereof, where adoption really seems to get hold and then kind of pass through the organization?
Well, that depends on the technology really and the application. So for instance, back on clinical communications, the way you get value out of that system is to have everybody on the same platform so you don't have islands of communication. Same thing with command center technology and capacity management. You're either all in or you're not getting the value out of it. But with things like virtual care and surveillance and central monitoring and also going into the home, you can do this incrementally. And that's where we're seeing a lot of organizations start in certain areas. Virtual nursing is another example where we've seen some hospitals that are trying to start with a few units and test it out and then refine it and then move it out into other areas. But areas where we see of great importance, first of all, in telemetry and med-surg is early detection and patient safety. These caregivers are spread out across many patients and broad geographies, so it's very hard to stay on top of the trajectory of each patient. Second would be in the ICU. They've got, how do they tame that incredible amount of data pouring in in the critical care environment and make effective clinical decisions in a timely manner. It takes so much time just to assemble the information and then make sense of it. How can we help with that? Another area would be in emergency care, response times, STEMI and stroke, as well as how do we ease the overcrowding. In the operating room, time is money. So, how do we improve speed and turnaround times? In the home, that's huge right now, and that's really an evolving area where we see these, connected care platforms really changing the game. But we have to get there with the home because that's really a major answer for capacity and financial challenges of healthcare. And then finally, just everywhere is just protocol compliance. It's surprising how often we see certain protocols not followed just due to how overwhelmed staff may be and the complexity of care. And it's when you follow those protocols that you achieve greater patient safety and outcomes and financial results.
I really appreciate your nod to the data overload, right? Cognitive burden and cognitive overload, as well as alarm fatigue, seem to be, still a very challenging arena. I think, it's really important that we, as an industry, recognize the importance of accuracy and relevancy of alerts and alarms. A, to be able to get the clinicians to be able to trust it, and B, to be able to get those clinicians to act upon it in a timely manner. What are you thinking about when you look at what we're doing in command centers, the digital CMUs perhaps as an example, that are really aiding in being able to A, get those clinicians to trust it and get them to be able to act upon to reduce latency?
So let's start with cognitive load, and let's also just start with alarm fatigue, because really in its current state, alarm fatigue is still unresolved. Hospitals ask us all the time, hey, can you drop in some AI and eliminate false alarms? And first of all, AI is not there, and it's not a panacea. And the jury is out for me whether it will really get us there, because are you going to trust an AI algorithm to turn off an alarm that's being called by a medical device? That's going to take some time, but we are using intelligence to aggregate alarms and have smarter technologies to limit the onslaught of alarms. So definitely we can improve on that. But the second piece of it is there's an eternal tug of war between patient safety and alarm fatigue. So the tighter we tighten the noose in terms of alarm response, the more we create alarm fatigue, and vice versa. And that's actually where central monitoring units came into play. Central monitoring units right now have really been the one truly transformative strategy that's addressed that dichotomy between patient safety and alarm fatigue. And there you have an intelligent monitor tech who is assessing, and they're well trained, so they know these are repeat alarms or these are not valid alarms, and they can truly filter out the alarms coming to the caregiver on the floor. We see reductions of 80–90% of alarms sometimes going to the nurse on the floor and enabling them to do their jobs better. But they're also very expensive. So we worked with Ascom, as you know, to develop the digital CMU solution, which allows us to remove most of the manual steps that a monitor tech must take in terms of managing, dispatching, escalating, documenting, and even having oversight over alarms, so that we can have techs monitor more patients with greater safety and improved results. And even going from a standard manual CMU to the digital CMU, we're seeing outstanding results. And then finally, just in terms of early clinical action, it starts with awareness. And we are seeing, and we've been seeing for years, people developing predictive technologies, whether it was the HERO protocol for sepsis that was developed. We've also seen a company out of Michigan called Fifth Eye that's developed predictive technologies for hypovolemia, hours, even potentially a day in advance. So we're also seeing the ability to more readily inform clinicians in advance of patient deterioration, whether it's early warning scores or these predictive algorithms. And then from there, again, layering on the protocol compliance.
So I got to segue into another area here, because I'm still grappling with this idea of enhanced clinical surveillance, all right? So we've talked about the digital CMU. We talked about going from a manual to an automated process. We talked a little bit about home monitoring. We talked a little bit about virtual nursing. And I don't necessarily want to call it a panacea, but there's this term, single pane of glass, that's out there. And in your mind, and you mentioned it already, it's really about policy compliance and making sure you're matching the right technologies and processes with what you need to do from a use case and workflow standpoint. But do you see this notion of a single pane of glass really being representative of what enhanced clinical surveillance should be, or do you have kind of a different definition of enhanced clinical surveillance?
Well, when I look at clinical surveillance, I really try to look at the applications that they're accomplishing. And so, first of all, we are seeing this sweeping trend across the industry of adding clinical oversight. So we talked about central monitoring units for telemetry and how effective those are. We're certainly seeing a lot of attention given to virtual nursing, where we're trying to support the nurse on the floor with a remote nurse who's helping them with admission tasks, discharge tasks, patient engagement, education, as well as tele-sitters watching patients getting out of bed and so on. But there's another area of virtual nursing that I call clinical oversight, where you have more experienced nurses helping perhaps less experienced and busy nurses on the floor, especially with their challenging patients. We lost so many nurses during the Great Resignation during COVID, and those were typically the most experienced nurses, as well as nurses get later in their career, they often aren't up to the physical tasks, and yet they still have such wisdom and knowledge that we don't want to lose. And so we want to have nurses operate at the top of their license and be able to support the nurses who may be on the floor and need help with certain patients or in terms of seeing certain cues. So one area was this example at HCA Continental Division, where they had experienced nurses providing oversight to less experienced nurses on the floor. Another area is at Baylor St. Luke's in Houston, Texas. They have kind of taken the rapid response team model and turned it on its head. Whereas once upon a time, a nurse would see their patient deteriorate, they would call in the rapid response team to assist. But now what we're finding is the nurses are so busy on the floor or miss those early cues that they're using these surveillance and predictive technologies. And at Baylor St. Luke's, they have 2 experienced nurses in a room watching surveillance of 400 or more patients. Wow. And it will say, hey, these 3 patients pay attention to right now. And then they can use the clinical decision support tool to further analyze and determine what needs to be done. And often they're calling the rapid response team and showing up at the bedside, and the bedside nurse had no idea that this was occurring and that their patient was going downhill. So they're saving lives. They cut ICU readmissions in half since they deployed that surveillance technology. So that's just one example of how we can change that model and really save lives and reduce costs at the same time. And then finally in the home, which is emerging, we're seeing all kinds of applications for remote monitoring as well as hospital at home that require this backup layer of surveillance.
That's fantastic. I didn't know those stats on the latency reduction and ICU bounce back. That's really impressive. I wonder if you could maybe put your futurist hat on for a minute, and
okay.
let's give nod to the industry, because I think we've done a good job in digitizing information, right, and really reducing latency, putting it in the hands of the clinicians, making it more contextually appropriate, right, so that it's not inactionable. But when you think about clinical performance and patient outcomes and trying to improve upon both of those, where do you see us going as an industry in the next 5 years?
That's an interesting question. And well, first of all, I feel like we have plenty of technology to go around right now, but how do we use it? And I think some of it is a bit more of the same, right? We're going to see the growth of AI and predictive technologies in the cloud, but I also think we'll use AI to also automate a lot of operational tasks and remove many of the manual steps that occur today to allow caregivers to focus on what they do best, which is care for the patient. The second thing would be around the home. I mean, really, when we look at in the U.S., we are at such a breaking point, and whether it's the level of chronic disease management that needs to occur, or moving patients into the home sooner to address capacity and financial and staffing challenges, all of these things point to a massive growth in home monitoring and home care of patients. I also see, I mean, with technology, things like integrated location services within the hospital. How do we improve visibility to process where patients are, where caregivers are, and optimize their workflows? Because, staffing, we have such a crunch in that area. And then finally, just eliminating proprietary systems. I mean, we're well on the way there, but how do we achieve true interoperability so that the data being stored in the cloud by the EHR can also be blended with the high-resolution data coming off medical devices and allow us, new forms of awareness or decision support or just new areas of workflow that we can enable with that. So I think just achieving true interoperability is still something to be achieved.
Excellent, excellent. Well, Angus, this has really been a true pleasure. I can't thank you enough for being here with us today. In addition to sharing just some keen insights, your experience in the market, what you've been able to do through GE and our partnership, I think is really, really impactful. And again, I just want to thank you for the time that you've shared with us today.
Well, I appreciate the opportunity to be here, Dave, and look forward to continued partnership.
Sounds great. Thanks again.
Thank you.